What's up, Ninja Nerds? In this video today, we're going to be talking about tubulointerstitial diseases. That includes ATN, which is acute tubular necrosis, AIN, acute interstitial nephritis, as well as renal papillary necrosis. Again, this is part of our clinical medicine section. If you guys like these videos, they make sense, they help you, please support us. You can do that by hitting the like button, commenting down in the comment section, or subscribing. All right, also, and I really think this would benefit you. Down in the description box below, there's a link that goes to our website. On our website, we have a lot of premium resources. We have notes, we have illustrations, we got quiz questions, we even have case series on certain topics. So go ahead and check that out, and I think that you'll benefit a lot. Without further ado, let's talk about tubulointerstitial diseases. All right, so let's talk about the pathophysiology of these diseases. It's really important to kind of have an understanding of these. We talk about actually these two, particularly in acute kidney injury, and that's really an important area to understand their significance. I just think it also deserves a potential, a little bit more talk about these diseases on its own. But again, do remember that acute tubular necrosis and acute interstitial nephritis are very common causes of what we call intrarenal AKI. All right, with acute tubular necrosis being like most often the cause, like 80 to 85% of the time. So when we talk about these, it is important to really talk about these in the concept of knowing that these are underlying causes of acute kidney injury. And the renal papillary necrosis can also cause AKI, and so it's a possible discussion there. But I wouldn't put all your eggs in that basket. I would focus on this as kind of one of those very interesting niche talks about, underlying kidney diseases, and that's where renal papillary necrosis belongs, is in the concepts of like these little niche areas such as hematuria and even potentially like infections like pyelonephritis. But we'll get into each one of these and we'll talk about them. I just want you to understand the importance of these is that these are really heavily discussed more in AKI. That one's kind of a little niche area, but we'll give a little bit of discussion on it. All right, acute tubular necrosis. Concept of this is that you're causing necrosis of the proximal convoluted tubular cells. It can involve other different tubular cells, but I'd say the most majority of the area of the nephron is going to be the proximal convoluted tubule. Now, the concept behind this is that what happens is there's usually two underlying mechanisms. One's ischemia, one's nephrotoxic mediated. Now, in ischemia, the concept here is that there is a reduction, we'll say, in what's called renal perfusion. And there's a lot of different reasons why a patient can have reduced renal perfusion. Oftentimes, it's just a very low blood pressure. So scenarios of hypotension or shock is a very, very common one, and we'll talk about those. But what happens is when a patient has prolonged, reduced renal perfusion or renal hypoperfusion, one thing that can happen is you'll have a hard time being able to filter as much blood across. So that'll lead to a reduction in GFR. But the big thing here is that the afferent arteriole who receives blood feeds it into the glomerulus. It should leave the glomerulus via the efferent arteriole and then run down through these little things called the peritubular capillaries. And guess what these are supposed to do? They're supposed to supply oxygen to what? To the tissues of the proximal convoluted tubule, the distal convoluted tubule, all of those different areas. Now, if for some reason you have a reduction in renal perfusion, you're going to reduce the oxygen delivery to these tissues. Whenever you reduce oxygen delivery to these tissues and it's not reversed, what's going to happen is these tissues will start to undergo ischemia. And as they undergo ischemia, if it's not reversed properly, these tissue cells will undergo necrosis and they will die. As they die, some of these tissue cells kind of slough off. So imagine it's epithelial tissue, they start to kind of like literally wither away and they slough off into this lumen of the proximal tubule. When they do that, now what happens is these like epithelial cells, they kind of like clog up this highway. They clog up the actual tubular lumen. The problem with that is that you want to filter things across here, but it doesn't allow you to. And so what happens is this starts causing, like as the filtrate's starting to filter, it literally causes this to build up. And when it builds up proximal to this area, right, what's going to happen is this is going to cause the pressure inside of the Bowman's capsule to go up. And so what we call that is whenever there's a pressure in here that increases, we say there's an increase in what's called capsular hydrostatic pressure. So capsular hydrostatic pressure, that is going to increase. When that increases, what it does is it actually leads to a difficulty in allowing for filtrate to cross the glomerulus and go into the Bowman's capsule. And that's glomerular filtration rate. And so what happens as a result of this is that these patients experience kind of a reduction in their filtration process because of this backup. And so what this does is this actually drops the patient's GFR, their glomerular filtration rate. And that will lead to, especially if it's rapid or abrupt, it'll lead to an acute kidney injury. And so that's one of the concepts that I want you to understand here, is that one of the reasons why patients develop acute tubular necrosis is that they have reduced oxygen delivery from reduced renal perfusion, and usually for prolonged periods of time. The other common cause here for these patients is that it could be nephrotoxic induced. In other words, maybe there's some type of like medication of sorts, and you become exposed to it, and what happens is some of it gets filtered and you can excrete that drug, but some of it continues to stay within the bloodstream, and maybe this drug has the capability per se to get taken up by these epithelial cells. And whenever this drug gets taken up, or these particular molecules get taken up by these peritubular cells, these contain the capacity or the intrinsic ability to cause destruction of these tissue cells. And so nephrotoxicity in this particular scenario could be due to multiple different things. It could be due to drugs, it could be due to other different types of pigments, it could be due to crystal formation. There's a lot of different things that we'll talk about with respect to these nephrotoxins. All right. So the two big concepts here is that it could be ischemia that's leading to poor oxygen delivery, or it could be a nephrotoxic substance that's causing tubular cell death. Either way, in both of these scenarios, the tubular cells slough off and they plug up this lumen. If they plug up the lumen, it leads to a back pressure. And what is that back pressure again called? It's called capsular hydrostatic pressure that goes up. And as the capsular hydrostatic pressure goes up here, it impedes the flow of filtrate out of the glomerulus. So you have an increase in capsular hydrostatic pressure that causes a decrease in the ability to filter things across the glomerulus, called a GFR. Right? And so this is what causes these patients to develop acute kidney injuries, because this is usually a rapid reduction in GFR. And then that causes an acute rise in their serum creatinine and a drop off in their urine output. All right, so we have an understanding now of acute tubular necrosis. This is going to be one of the most important tubulointerstitial diseases to be able to identify. The next one is acute interstitial nephritis. I like to think about this as an allergic reaction, essentially. There's some type of exposure, all right? We're gonna call this exposure, we're just gonna say it's an antigen. And this could be a lot of different things, if you will, but we have an antigen exposure, all right? Maybe that's a drug, maybe it's an infection, maybe it's an underlying inflammatory response from an autoimmune disease. Whatever it is, these patients become exposed to this antigen and it gets into the bloodstream. When this antigen gets into the bloodstream, it maybe does not have exactly, per se, a immunogenic potential, let's say. In other words, it wouldn't be able to activate the immune system. But if we go ahead and we connect this to a little molecule here, maybe we bind onto this a protein. That protein, when bound with the antigen, now forms something called a hapten. And so now you have something called a hapten. Now haptens are highly immunogenic, meaning that our immune system would identify this antigen and protein complex and say, oh, what this is. And when it sees that, the problem with this is it's going to go ahead and say, okay, I'm going to bring my macrophages to here, and it's going to go ahead and phagocytose this. And so it's going to undergo a phagocytosis mechanism. When this phagocytosis mechanism occurs, what you're going to see here is it's going to take up this hapten and maybe express a piece of it on its MHC2 complex. And so this macrophage will then say, okay, or this antigen presenting cell will say, okay, let me present this to a T cell. When it presents this to the T cell via its T cell receptor and connecting with the MHC2 complex, this creates an interaction, if you will. This interaction causes hyperstimulation of the T cells. And what these T cells start to do is they start to release a bunch of cytokines. It's going to release a ton of different cytokines. But I think some of the cytokines that are actually potentially worth remembering are cytokines. There's a couple of them, but I'm going to put one big one. It includes interleukin 5. What you may know about interleukin 5 is this has a very strong effect on eosinophils. Eosinophils love this cytokine. And so what happens is these cytokines come and stimulate these eosinophils. And this is particularly occurring a lot in the kind of renal interstitium area. So here between the cells and the blood vessels. And so this is going to activate these eosinophils. And now you're going to have all of these eosinophils who are going to kind of be hyperstimulated. And there's going to be other immune system cells. It's not just eosinophils, but you're going to really stimulate these to go and infiltrate into this tubular interstitial area. And what they're going to do is they're going to start kind of accumulating all here. And they're going to release more cytokines, and there's going to be lots and lots of inflammation here. So there's going to be tons and tons and tons of inflammation. Let's represent this with like this blue color. And so now you're going to have all of this inflammation that's occurring around this area here with all of this cellular infiltrate. What's going to happen is all this inflammation and edema in the interstitial area is going to start having a mass effect. And what it's going to do is it's going to start compressing on the tubules. Look at this tubule, and then look at this tubule. You see how much like more narrow this one is? So you get a compression of the tubules. All right, so this increasing edema will cause tubule compression. And what that'll do is it'll make it harder for this filtrate that's being filtered off to run down. It's going to be kind of obstructed there. And what that's going to do is as blood kind of comes into the glomerulus, it's going to be harder for it to filter if this is building up. And again, this tubule compression is going to lead to an increase in the the capsular hydrostatic pressure, which will drop off the patient's GFR. So you're going to see an increase in the capsular hydrostatic pressure, which will drop off the patient's GFR. So it's a similar concept when you really think about it, in the sense that something is obstructing that flow. You can't get things down here. And it was the same for acute tubular necrosis. The difference is that you had cells that were blocking up the lumen. Here there's a lot of edema. And that edema is really what's causing compression and external compression of the tubules. And if I'm stimulating this increased tubular compression, that's what's going to drive down my GFR and cause an acute kidney injury. So that's a concept that I really want you to understand here, is that they're going to have a lot of edema and inflammatory infiltrates with eosinophils, other white blood cells, but this is the real big one here. And oftentimes it's some type of antigen that's triggering this process. That's the big thing to remember here, guys. All right. So we have acute tubular necrosis. All right. I kind of got an idea. Ischemia, nephrotoxins. Okay, cool. Not too bad. I know the primary mechanism behind it is that the dead cells are blocking up the tubular lumen. Acute interstitial nephritis is an antigen exposure that's causing a type 4 hypersensitivity reaction, which is a T cell mediated inflammatory reaction. That's causing a lot of edema, inflammatory infiltrate, compressing the tubules and knocking off that GFR. The last one is a little bit more kind of different, all right? And it's called renal papillary necrosis. The concept behind this, the primary mechanism is usually the patients are experiencing enough renal ischemia. So in other words, they're not having enough blood flow to their kidneys. Or you're like, Zach, wouldn't that be acute tubular necrosis? In a way, it's just a slightly bit different. With acute tubular necrosis, the primary problem is you're not perfusing the glomerulus and getting the actual kind of the cortex areas. Those tubular cells are getting necrotic. With renal papillary necrosis, the most common area to be affected is when you look at the kidney here, you see these kind of like triangles here, these particular areas. These are called your renal papillae. So you have these things called your renal pyramids. If you guys go back to your anatomy, these are your renal pyramids. And then up here would be the cortex, and then down here would be the papilla. This is the area that is the most prone to causing necrosis, undergoing necrosis. So what I want to do is I want to take this area and I want to zoom in on it and take a better look at it. So let me explain something. The concept behind here is that you have blood flow coming up through this area. And then here at the papilla, you have these tight little blood vessels called the vasa recta. If there is not enough renal perfusion, maybe there's an obstruction of the vessel, maybe something is compressing the vessel, but whatever it is, I'm just not getting enough oxygen delivery to these tissues. That's going to cause the same exact concept that we talked about before. So you're going to have a renal blood flow here, but you have to look at this a little bit differently. As renal blood flow is coming in via the vasa recta, if there is some particular reason as to why we are not dropping off oxygen, there is a decreased oxygen delivery, then what's going to happen is this tissue is going to start to undergo ischemia. And as it starts to undergo ischemia, it will start to die. And so what will happen is this patient will undergo what's called papillary ischemia. So they'll undergo papillary ischemia that then, if not treated, will lead to papillary necrosis. So then that's what we have to think about, is what's actually causing this reduction of oxygen delivery to the renal papilla. That's really the question that comes about here. Because the problem with this is, if this tissue starts to die, imagine all of this tissue here dies. Guess what can happen? If this tissue dies, it can literally kind of slough off here. Such a weird word, slough. It could slough off into the actual renal calyx, and then guess what? This tissue, which I'm going to kind of represent here in black, could get stuck. It could literally get stuck in the ureter and create an obstruction. This can cause urinary stasis proximal to that and cause increased risk of infection. It can block off the filtrate and lead to an AKI. So this is definitely something of why we would want to be careful about this one. So now at this point, what I've left you guys with is that we have 3 tubulointerstitial diseases to talk about: ATN, AIN, renal papillary necrosis. All of them have slightly different pathophysiology. What I need you to start asking is, what's causing this particular disease? All right, so let's talk about the causes of each one of these tubulointerstitial diseases. So when we talk about acute tubular necrosis, we know that there's primarily ischemia related and then nephrotoxic mediated. Either way, there's death of these tubular cells. They're causing these kind of cells to get blocked up into the tubular lumen, increase the pressure inside of the tubular system and the capsule, which reduces the net filtration, right? That's the concept here. The thing that you have to start asking yourself is, what's causing that reduced renal perfusion? What are those nephrotoxic medications? And so oftentimes the ischemic causes that lead to reduced renal perfusion can come down to this diagram here. Let's say that a patient has cardiogenic shock. If they have cardiogenic shock, where maybe they had an MI, maybe they have acute heart failure, and in this scenario they have disease of their pump. The problem is with their pump, and so now their ability to get blood out of the heart is impeded. So that's one potential mechanism, right? Is really prolonged cardiogenic shock. The next concept is, let's say that the heart is pumping well, but maybe the blood vessels are super vasodilated. So there's disease of the vessels. So maybe here I have some type of disease process of the vessels, and what's happening here is that maybe they're super dilated. Because in this one, it's reduction in cardiac output, right? That's the primary mechanism here. Here, it's that it's vasodilated. And oftentimes, this is an example of what we call septic shock. And usually this is a reduction in the systemic vascular resistance, where the vessels are just super dilated, right? That could also drop the blood pressure. So both of these, this reduction in cardiac output leads to a reduction in MAP. Decrease in SVR leads to a decrease in MAP. The next thing is, what if the vessels are underfilled? What if you don't have enough blood volume in them? And so the other concept here that you have to be able to ask yourself is, what if the circulation is not properly filled? And so when I look at this, I'm not having enough blood volume to fill the actual vessel and deliver oxygen and nutrients to the tissue. And so that would be another potential scenario here. So it could be cardiogenic shock, septic shock. The last thing is, what if it's hypovolemic shock or hypovolemia? So hypovolemic shock. And in this particular situation, the blood volume is the problem. And if you have a reduction in blood volume, you will lead to a reduction in the end-diastolic volume, the preload, the contractility, and then the cardiac output. I'm sorry, their preload and then their cardiac output. So this is also going to drop their blood pressure. Either way, in all of these scenarios, the problem that exists here is that you're not perfusing these kidneys. And if you're not giving oxygen to the tissue, right, what is going to happen? It will then undergo ischemia. And when it undergoes ischemia, this will lead to acute tubular necrosis if it is not fixed. So if we don't reverse that cause, all right, if it's prolonged, that's really the case here. If it is prolonged low blood pressure, this will lead to necrosis of the tissue, all right? And so that's the big difference here that I want you guys to understand. So what you have to look for in these patients is there any history of low blood pressure. So you need to assess. The big thing here is you need to assess for hypotension, so assess for a decreased blood pressure, right? That's one really big thing, but also look for other features of poor perfusion. So mottled skin, and cold extremities. Also, I would look for potentially elevated lactate levels that suggest poor organ perfusion. So a lot of these things could suggest that being the likely cause. But oftentimes, it's just looking at their history to find what's really going on with the patient that would suggest, oh, this is ischemic related rather than nephrotoxin mediated. The next thing that I would also want you guys to think about for these patients is if I have a patient coming in with an acute kidney injury, right, and I think it could be ATM, and I don't really have any history that suggests that their blood pressure has been really low, that they don't have any parameters of poor organ perfusion, then I would start thinking about, have they had any exposure to nephrotoxins? Drugs are often the first thing that I'll go to the history on, and I'll look through their medication history. I'll look for some classic drugs. Aminoglycosides tend to be a really big offender, so this is an antibiotic. Cisplatin, which can be used as kind of a cancer agent, a chemotherapy agent. Another one could be amphotericin. So I like to think about this one as amphoterrible, which is used in fungal infections, usually systemic fungal infections. The big one that I would want to watch out for is iodinated contrast. And this is a really big one. We talked about this in acute kidney injury. We talked about this in chronic kidney disease, that contrast-induced nephropathy is something that you have to be careful for. With iodinated contrast, it can do two things. One is it can cause vasoconstriction. So it can vasoconstrict the afferent arteriole, right? So if I vasoconstrict this puppy here, right, it's gonna make it harder for blood to get into the glomerulus, right? And that'll reduce the filtration, but it'll also make it harder for me to give the actual blood flow to these tubular cells. And so there will be a reduction in oxygen kind of inadvertently here, all right? And that can cause some death to these cells. The other concept here is that this iodinated contrast may just have nephrotoxic properties. And so it's also important to remember that this drug could just directly, without having any kind of problems with ischemia, could also lead to nephrotoxicity. And so the concept here is that it may cause increased vasoconstriction of the afferent arteriole, reduce blood flow via the glomerulus, and also just stimulate direct nephrotoxic activity. One of the big things here that we always talk about here is you can try to prevent this by giving IV fluids to the patient pre and post contrast administration. So when a patient gets the contrast, before that, give them fluids, and then post-contrast delivery, give them fluids. That may help to reduce the risk of causing ATN and leading to a nasty AKI. All right? Second one is pigments. Now pigments, there's two types that I want you guys to remember about. One is myoglobin. And so with myoglobin, we see this coming from oftentimes skeletal muscles, and the other one is hemoglobin, which is going to come from our red blood cells. And so as you see here, we have a perfect setup here. There's one disease that causes a lot of myoglobin to get released from a tissue, and this is usually skeletal muscle cells that are rupturing or breaking open. And we call this rhabdomyolysis. This happens in patients who have seizures or crush injuries, or they've been taking a certain drug like a statin of sorts. And this causes these skeletal muscles to kind of bust open a little bit, and they release out things like creatine kinase, which is kind of a marker of rhabdo, but it also releases out that myoglobin. And the myoglobin is what's really kind of like dangerous. CK is oftentimes a parameter that we use as an aid to diagnosis, but the myoglobin is the thing that actually causes this disease here. Because what happens is this thing is going to run down through the glomerulus, get filtered out, and when that myoglobin gets filtered out, it can actually kind of directly cause damage. It gets taken up by these tubular cells. And when it gets taken up by these tubular cells, guess what? Well, daddy's home and he's going to cause some jacking up of this problem here. So that's the concept here with the myoglobin. So you really want to look for seizures, crush injuries, increased CK, and an increased myoglobin, or a urine myoglobin. Because we don't usually test the serum myoglobin, we'll test the urine if myoglobin, right? So if we test for actually like the myoglobin in the urine, that would come back positive. The next one is hemolysis if we're talking about hemoglobin. So hemolysis, I would really more likely see this with a transfusion, especially if it's acute, because this is acute problems. I would see this in like a transfusion reaction. So they just got a transfusion, had a poor reaction to it, and then developed a hemolysis of red blood cells. And so what would happen is that would cause your red blood cells to get popped right open, right? And it would release hemoglobin. And that hemoglobin would then do the same thing. It would kind of get filtered off, get taken up by these actual tubular cells, and that would cause direct injury to these actual tubular cells, right? The other concept here is that when we release this hemoglobin into the bloodstream, right, you're also doing something else to the red blood cells. You're also releasing something called LDH. And LDH is kind of a marker that kind of tells us that we potentially are busting open a lot of these red blood cells. Another thing is that as hemoglobin is released into the circulation, it gets bound to another protein, and this protein is called haptoglobin. And so haptoglobin is kind of a free circulating protein, so imagine it here in pink. We kind of measure it based upon if it's free or not. If it goes and binds onto hemoglobin, then we lose some of that haptoglobin that's free, and now some of it is bound to the hemoglobin. And so what happens is the haptoglobin levels will start to drop as it binds more and more of the hemoglobin. And that's other ways that we can tell if a patient has underlying hemolysis that's going on. All right? Next one's crystals. This is actually kind of like a very interesting one. We can see this in a couple drugs. Acyclovir is one that we can give to patients who have underlying viral infections of sort, maybe herpes simplex. But the real good one that we can kind of do for an exam is called I kind of gave the answer away, dang it. It's uric acid crystals. And so these uric acid crystals are something that we see as a result of a disease called tumor lysis syndrome, because this would be a very, very significant acute event. What happens is the patient has like lymphoma, maybe non-Hodgkin's more likely, or they have acute myelogenous leukemia, and then they just get a bunch of chemotherapy. When they get a bunch of chemotherapy, they bust open these cells. They release things like phosphate, they release things like potassium, they release things like LDH, and they even release a couple other substances, but the big one tends to be uric acid. Oftentimes there's a mnemonic called PUKE, which is phosphates, uric acid, potassium, and that's kind of the ways that and then E is elevated. These are all elevated phosphate, potassium, and uric acid, but these are going to be released a lot. So you have lots of uric acid, lots of LDH, lots of potassium, lots of phosphate. So these are going to be some things that get released as a result of these tumor cells busting open. But the one that actually causes disease is the uric acid. Because what happens is this uric acid, you get a bunch of it, it starts to kind of bind with other molecules, so other uric acid molecules, and they start to precipitate. And when they precipitate and crystallize, they can obstruct the lumen, but they also have the capabilities to cause direct injury. And so they also can destroy these tubular cells. And so that's the concept here, all right? So when we're thinking about these, you're kind of looking through their medication lists, looking to see if there's any history of seizures, crush injuries, drugs that can cause rhabdo, looking for hemolysis, and look at these parameters, look at some of these labs, looking for a history of cancer with recent chemotherapy with some of these labs. All right. The last one's really tough. This one's usually due to what's called Bench-Jones proteins. So we have a lot of what's called immunoglobulin light chains. We just call this Bench-Jones proteins. We see these primarily in a disease called multiple myeloma. So multiple myeloma. This is a plasma cell dyscrasia that basically these plasma cells are pumping out a bunch of proteins. But these proteins that they're pumping out, unfortunately, they're producing a lot of these like light chains. And what happens is some of these proteins that they're producing will get circulated throughout the bloodstream. And what they'll do is some of them may kind of like combine and precipitate. And what they do is they love to kind of get stuck in the proximal tubule. And when they get stuck in the proximal tubule, they obstruct that flow. And on top of that, they cause direct nephrotoxicity. And so that's another way that we can think about these. These are these proteins that the plasma cells are releasing, lots of these light chains, these Benz-Jones proteins, and they can also cause this. Big thing to remember though with this is that with multiple myeloma, it's also associated with a very common thing called the Crab criteria. I'm not going to go through the whole thing. I'm not going to write it all out, but I want you to remember the Crab criteria. What I mean here is that these patients oftentimes will present with hypercalcemia, because it goes hypercalcemia malignancy, renal failure, such as an acute kidney injury, sometimes even CKD, anemia, and then lastly, they can also present with bone pain because of the lytic lesions caused by the actual plasma cells, all right? So this is the big thing that I need you guys to remember for ATM, is thinking about these as potential causes that we have to analyze in a patient who has an acute kidney injury. And we suspect, oh, it's ATM because I've gone through and I figured out they have muddy brown cast, they have features on their urinalysis which suggests that they have ATN. We'll talk about those things. And their phenon, urinosmolality all suggest this. What's the reason? Is it ischemic? Is it nephrotoxic? And then go through these things in the systematic way we talked about. If you've gone to a patient, they come in, they have an acute kidney injury, right? Creatinine's up, urine output's down, have a drop off in the GFR, you're like, I don't really have anything that's really pegging me off to think about ATN. Then you can start thinking about AN, especially if they just recently started a drug. Oftentimes, acute interstitial nephritis, most commonly, I mean, I'm not kidding, like most of the time, and you'll most likely get a question on these more than you would get for infections. It's very rare, but you can see this with Streptococcus pneumonia, and you can see this with SLE and maybe even Sjogren's syndrome. But I'd say it's way less likely that you'll see this and then also get tested on this. It's more likely that you'll get tested on the drugs. And so there's a lot of them, and it's hard to remember everything. And so one of the things that I think is best for us to do is use a mnemonic. And so I like to remember darn sap. And so I remember this based upon D is for what? All right. Well, there's a bunch of different drugs, but diuretics tends to be a kind of a potential offender here. And so I think about loop diuretics, I think about thiazide diuretics as a potential possibility here. A, I like to think about antibiotics. And I would say, more likely than not, if you see a question where a patient just got a beta-lactam, penicillin, amoxicillin, cephalosporins, any of them that have a beta-lactam ring, that is likely going to be the most common trigger. All right, especially for your vignettes. Other ones that you potentially could think about is rifampin. We can use this in tuberculosis. So that's something also to potentially think about. Another really big one is NSAIDs. NSAIDs can also do this, all right? So non-steroidal anti-inflammatory drugs. Now, other ones could be sulfa drugs. Any kind of sulfa drug could do this. Bactrim, any kind of drug that has a sulfa group on it. Another one is allopurinol. Allopurinol, we actually use this in patients who have underlying gout and sometimes in tumor lysis syndrome. And here's another really big one. Proton pump inhibitors, like omeprazole. So I'd say out of these, which ones are the most likely they'll present in a vignette as a patient who comes in, they've just taken a medication such as a beta-lactam, an NSAID, or a PPI. Then after that, that patient developed an acute kidney injury as well as other features, a triad of AIN. We'll talk about it for right now. I want you to trust me that it's usually a fever, a rash, and eosinophilia, all right? Then you would start thinking about AIN, and you would start looking through these potential drugs and just get rid of them, all right? Oftentimes, more than not, what is this? This drug is the antigen. So this is the drug that, like when we talked about before, this is the drug that we become exposed to. And once we become exposed to this drug, it binds onto a protein that we are exposed, like we have in our body. And once we bind these two together, this produces that combination of the drug and the protein, which we now call what? We call this a hapten. And that hapten, if you remember, is what's immunogenic and triggers that whole process. So here is the drug. And then over here, we will have some type of circulating protein molecule, if you will. These two, when combined together, make a happen, and that's what triggers this immunologic kind of reaction that triggers lots of inflammation and edema in the interstitium of the renal tubules. All right, cool. We hit this one. We come to our last one over here. The last scenario here is going to be renal papillary necrosis, my friends. This one's a tough one. I wouldn't say that this is an easy diagnosis to make, all right? Oftentimes, a patient who has renal papillary necrosis, they'll come to you, and they'll come in with maybe flank pain, maybe some hematuria, but they won't have a lot of other symptoms. Oftentimes, they can be completely asymptomatic. What you really want to think about with renal papillary necrosis that really helps you to think about this one is the causes. So we know that it's the papilla, right, or at the deepest part of the pyramid that's undergoing necrosis because of the vessels. You have small little vessels there, and if for some reason you get kind of like an obstruction or compression of that vessel, you're not going to get enough blood flow, it'll become necrotic, it'll slough off, and you can obstruct kind of your calyx or your ureteral system. So we get that. But what's causing that is the question. There's many things, and I'll talk about the biggest ones that I think are highest yield for your kind of exam, but oftentimes we use what's called the postcards mnemonic. And we say that this could be due to pyelonephritis. Now, funny enough, patients who have renal papillary necrosis can cause, it could lead to pyelonephritis because you can obstruct their ureter system and lead to bacterial stasis proximal to that obstruction. But also, pyelonephritis causes an obstruction of the ureter, which can cause a back pressure, and that back pressure can cause swelling inside of the kidney, and that can compress those tiny little vessels at the papilla, and that can lead to ischemia. Another one is an obstruction of the urinary tract. And so, funny enough, again, same concept. So pyelonephritis causes inflammation of the kidneys. The inflammation of the papilla squeezes the vessels. An obstruction of the urinary tract, like a stone that gets stuck somewhere present within the ureter or the calyx, obstructs that flow and causes the pressure to build up and compresses those small vessels. Another one is sickle cell. This is a pretty big one. So patients who have underlying sickle cell anemia, they can have those red blood cells that they can sickle and get stuck. So if I get like a nice little good sickled cell red blood cell, that sickled cell red blood cell can get stuck inside of our capillaries, those small little vessels supplying the renal papilla. Boom, you get ischemia and necrosis of that tissue. Another one that's like super rare, honestly I didn't even want to put it on the list, is tuberculosis. I'd say this is kind of a rare cause. So the next one would be cirrhosis. Now cirrhosis is kind of interesting. We can see this one as well. It's usually due to portal hypertension that you cause, the release of splanchnic vasodilators, and that kind of dilates your vessels and reduces the renal perfusion because it kind of takes blood away, all right, and it kind of diverts it to the GIT and instead pulls it away from the kidney. It also activates that renin-angiotensin-aldosterone system, which vasoconstricts your blood flow to the glomerulus. Another one, this is a really big one, is analgesia. And we see this with NSAIDs. So you're like, okay, Zach, wait a second. How do I know if it's the NSAIDs that are causing AIN versus the NSAIDs that are causing renal papillary necrosis? They're completely different presentations, and you should be able to pick that up off of the vignette. We'll talk about that. Another one, kind of less likely, is renal vein thrombosis, especially if you have a patient that you think has an underlying nephrotic syndrome, such as membranous nephropathy. I would think about this one. Analgesia, we'll talk about the mechanism. Renal vein thrombosis, this works by blocking off the renal vein, and that increases the compartmental pressure within inside the kidney, and that will cause compression of those small renal vessels. Another one is a really big one, and this is diabetes mellitus. Very, very common. So diabetes mellitus can actually cause hyaline arteriosclerosis, and it can really cause a lot of plaques to develop within those smaller renal vessels. And the last one that I would also think about is like systemic vasculitis. So any kind of vasculitis has this capability to cause some type of process like this, even like polyarteritis and the dosa. So out of these, which are the ones that I really want you to think about? And the reason why I want you to think about them is because they have mechanisms that you could be tested on, but also if you think about patients who have underlying diseases, you want to think about the ones that are kind of like treatable, right? NSAIDs, the concept behind this is actually kind of cool. NSAIDs work by kind of shutting down prostaglandin I2. And so what's happening is you're supposed to cause vasodilation of these renal vessels, right? Especially the vasa recta. If you have less PGI2, it's going to cause less vasodilation and instead cause vasoconstriction, because that's the concept here, is that if I have NSAIDs, what these are going to do is they're going to decrease PGI2. They're going to inhibit the cyclooxygenase enzyme, and that's going to induce an increase in the vasoconstriction of these small renal papillary vessels. And then as a result, if I vasoconstrict these puppies, then what's going to happen? I'm going to get less oxygen to this tissue, it's going to become necrotic, And as it does become necrotic, it's going to slough off some of that tissue into the calyx and into the ureteral system. Sickle cell is actually kind of interesting because, again, you get these like little sickle cells, and these little sickle cells go and they get stuck, right? So if I have these sickle cells and they kind of try to move and maneuver into this renal papillary vessel, they're going to start plugging up this whole vessel. And as you plug up this vessel, you're not going to be able to get oxygen to this tissue. If I can't get oxygen to this tissue, what's going to happen? It's going to start undergoing necrosis. As it necroses, it starts to die and shed and slough off some of that renal papillary tissue. And then lastly, diabetes, we know about this one, it's going to cause a lot of arteriolosclerosis, right? Because we know that diabetes causes non-enzymatic glycation, and that kind of causes a lot of arteriosclerosis. And if you cause arteriosclerosis of these vessels, what are you doing? You're kind of thickening up these vessels and you're narrowing that lumen. If I narrow that lumen, how hard is it going to be for me to get blood flow into this puppy? It's going to be pretty difficult. And as a result, this tissue will start to become ischemic and necrotic, and it'll start to slough off some of that tissue. And so I think that's the big things to be able to remember with these patients is that, again, you're looking at this in the sense of what is causing me to not give enough blood flow to the renal papilla. It's usually due to an obstruction in the lumen of the vessel, such as in diabetes, sickle cell. It could even be in the scenarios such as other diseases like maybe external compression. So things like pyelonephritis can cause an external compression because of inflammation. Obstruction of the urinary tract is increasing the compressor inside of the kidney. Even renal vein thrombosis, increasing the pressure inside of the kidney, and you're squeezing on that vessels. It could be vasoconstriction of the vessels in the scenario of NSAIDs, right? And so I think all of these are things that you have to think about is how are we causing papillary ischemia? All right, now that we've gone through each one of these guys' pathophysiology, their causes, now what we have to do is say, okay, what are the likely presentation of these patients? How would they come and see us as a practitioner, and then how would I analyze those complications that they're presenting with and say, okay, I need to get a diagnostic approach going on here afterwards. Let's do that. All right, so we have a patient who comes in, all right, maybe they have acute tubular necrosis. You're trying to figure out what are the likely presentation or complications that they may come in with. Oftentimes an acute kidney injury is the primary way that we would find acute tubular necrosis, right? So the concept behind this is also, again, repetitive to some degree in the sense that you have these tubular cells that have died due to ischemia or nephrotoxins or whatever it may be. And whenever they die, they kind of plug up, they slough off, and they start plugging up this tubular lumen. When you plug up the tubular lumen, we know that this is going to impede the flow of filtrate, right? And what we know is that this will increase the capsular hydrostatic pressure. And as we increase the capsular hydrostatic pressure, that then shuts off the natural flow of what we would say is the GFR, right? So we're going to shut down the GFR. So there's, again, an increase in the capsular hydrostatic pressure, and this increase in capsular hydrostatic pressure will shut down the net filtration, right? And as a result, the patient will start to have less urine output, right? So if you're not filtering things down through the tubular system, you will start to expect a decrease in the urine output. What do we call this? So we call this oliguria, right? So they can have oliguria. The other thing is that if you are having, again, blood contains all kinds of different things, right? Especially waste products. If I'm not filtering these things across the glomerulus, what's going to happen? They're going to stay in the bloodstream. And so often the primary marker that we look at for an acute kidney injury is that these patients will have an increase in their serum creatinine and an increase in their BUN. And so that's what I want to watch out for, is an increase in the creatinine. And again, if you remember what the numbers we described them as in the AKI lecture, and an increase in the BUN, right? The other thing is that this can also cause a lot of other problems, right? So these patients can start to experience a lot of complications of AKI. What are some of these AKI complications? It can cause an increase in potassium, increase in water, and an increase in protons. And so these patients are high risk for hyperkalemia, they're increased risk for hypervolemia, and increased risk of acidosis. So if a patient retains potassium, retains sodium and water, and retains protons, these are high risk for things like hyperkalemia, hypervolemia, acidosis, and these two can lead to uremia. And so that's the things that you have to watch out for here is hyperkalemia, hypervolemia, acidosis. Usually this is a anion gap metabolic acidosis. And then lastly is uremia. So this is azotemia, which is kind of an increase in the metabolic waste products, but if this causes complications, it can lead to uremia, especially things like encephalopathy, pericarditis, and bleeding. So we talked about that in AKI, but that's one of the biggest things that we have to be concerned with. Another thing that's really important here is when we test these patients' urine, they have very interesting FeNO findings. So what we find is that they have a high FeNO. So what I mean by this is that they have a FeNO that's usually greater than 2%, and they have a urine osmolality that suggests that the patient is not able to retain water, so it's less than 350. And let me explain that for a quick second. So when we talk about these patients who have acute tubular necrosis, what we know is that they have a kind of a high FeNO. And this basically tells me, are they able to reabsorb sodium or not? So what I want you to remember is that, again, these tubular cells are dead. It's most likely proximal, but you can affect other tubular cells. What happens is normally you're supposed to be able to reabsorb sodium in the proximal tubules and the distal tubules. And usually this is regulated by hormones, right? So this one in the distal tubule is usually aldosterone regulated. And then the one here in the proximal tubule is like angiotensin 2 or just even like, regulated based upon passive and active movements. But even if angiotensin 2 is present and aldosterone is present, it wouldn't really matter because these tissue cells are damaged and their ability to respond to these hormones doesn't really matter. And so their ability to reabsorb sodium across the proximal and distal tubules is impaired because it doesn't matter if these hormones are present or not. As a result, you don't reabsorb sodium across the tubules. And so as a result, the sodium retains in the tubular system and gets peed out. And so these patients have a very, very high urine sodium. And when you look at their high urine sodium and you plug it into the equation of FeNO, it's going to give you a high FeNO. All right? Urine osmolality is also a concept here where water is usually reabsorbed across the proximal tubule and the distal tubule. Now it's primarily modulated here based upon osmosis, and here it's regulated by ADH. Right? It wouldn't matter though, even if ADH was in high levels or not, because if these cells are damaged, their ability to respond to these hormones or their ability to reabsorb things is impaired. And so what happens is you don't reabsorb water. So the ability to reabsorb water is lost. And so as a result, the water stays within the actual tubular system and gets lost into the urine. And as a result, you get a ton of water in the urine, and we call that a dilute urine. And whenever you have a dilute urine, the tonicity or the osmolality of that solution is then going to be low. And so that is what causes that low urine osmolality, which we're going to abbreviate UOSM. So that's the concept I want you guys to understand here with ATN. We talked about this a little bit in AKI. This is just a nice recap. The last thing, and again, we kind of talked about this multiple times already, but really important to acute tubular necrosis is when you assess these patients' urinalysis with microscopy. So you take a look at their UA with microscopy. What we will notice is that these dead tubular cells, whenever they kind of like slough off into this tissue, into the lumen, they take on the shape of the lumen. And so what it does is it kind of forms like this weird kind of shape here, which we call a cast. And so this is what we're going to say is a cast, which is basically a clump of epithelial tissues, right, that is formed by the proximal convoluted tubular cell lumen. And we call this muddy brown cast. This is super characteristic of a patient with ATN. All right. So ATNs will present with an acute kidney injury, potentially complications associated with it, but look for these urinary findings to really help you reel in the concept of ATN as compared to these others. All right, so now we talk about acute interstitial nephritis. Again, this is not a very common cause of AKI. In other words, when we talk about AKIs, pre-renal AKIs, 67% of them are pre-renal. And when we talk about intrarenal AKI, like 80 to 85% of them are ATN. So it leads like maybe 10 to 15% of the patients who have AKI to have, acute interstitial nephritis if it's intrarenal. But either way, it's something that we have to be considering. So if a patient has recently taken a medication, one of those darn SAP medications, right, then you should be thinking about this, especially if a patient comes in, they have an acute kidney injury. Again, concept behind this one, if you guys remember, we had some type of inflammatory cell infiltrate. So you were exposed to the drug then did what? Bound with a circulating protein. That circulating protein became a hapten. The hapten has immunogenic potential. The immunogenic potential led to antigen-presenting cells doing what? Presenting that hapten to a T cell. T cells then say, okay, let me go ahead and release a bunch of cytokines, homie. Releases a bunch of cytokines like interleukin-5. And then what they do is they recruit lots of immune system cells, but I'd say the big one is eosinophils into this interstitial lumen, interstitial tissue area. What that does is increases the edema. And when you increase this edema here, what is it going to do? It's going to start compressing. It's going to start squeezing on the tubular system. As you compress the tubular system, you narrow the lumen. As you narrow the lumen, you make it sure as heck harder for things to filter across here. As you can't filter things across the glomerulus, things begin to build up in the bloodstream. Right? And then also, you lose the ability to make urine. So it's the same concept as ATN, right? As blood kind of comes through here, I lose the ability to make that urine, so that goes down. And I lose the ability to get rid of waste products. And so these waste products begin to build up in the bloodstream. And so again, same concept, I'll experience a decrease in urine output, increase in creatinine, increase in BUN, potentially complications such as an increase in potassium, increase in sodium and water, and an increase in the acidosis. So again, what is it called when we have a reduced urine output? My friends, this is oliguria, right? And if it makes no urine, it's anuria. Increased creatinine is a really big one, right? Increase in the BUN, this is called azotemia, but if it builds up enough that it causes complications, we can call that uremia. Build up in potassium, a build up in sodium and water retention, and a build up in protons. What does these things again cause? This can lead to uremia if it causes encephalopathy, pericarditis, and bleeding. It can lead to acidosis, hypervolemia, and hyperkalemia. And again, this acidosis is a anion gap metabolic acidosis. This hypervolemia can lead to a lot of edema features, and the hyperkalemia can lead to EKG changes and arrhythmias. So we know that this is a potential presentation, right, of a patient developing an AKI. What I think is important to remember is that these patients who have AKIs, they oftentimes not only present with these things, but other features that separates them from ATN. So AIN, they can have variable urine osmolality, variable phenols. And what's really interesting is that they oftentimes will present with a triad. And when I say oftentimes, on your boards all the time, in true clinical reality, 10% of the time. And this triad is often consisting of things like a fever. So watch out for a fever. Watch out for a morbilliform rash. And then lastly, because of that interleukin-5 that's heavily secreted, watch out for increased eosinophils or eosinophilia. Now, the other thing that in real life has very, very, very low sensitivity and specificity and utility is a urinalysis for these patients. So if you test the urine for these patients, what will happen is when you do a urinalysis with microscopy is you may see something that suggests that there's a lot of white blood cells into the urine. So you may see a lot of white blood cells that are getting kind of stuck into the shape of this actual tubular lumen. And when you go ahead and you actually look at these under the microscope, again, what you'll see is that you'll have white blood cell casts. But when you look at a lot of these white blood cells, what you're going to notice is that they contain lots of eosinophils. Again, the likelihood of this on the actual clinical reality is very, very low. Urine eosinophils doesn't actually kind of tell me that a patient has AIN in true clinical reality. It can be any kind of disease. But for your exam, if you see high urine eosinophils, an AKI, fever, rash, definitely be thinking about AIN, especially if they had a recent drug exposure. The last one is renal papillary necrosis. Now this one's interesting. The chances of causing an AKI is kind of rare. What would have to happen here is you would have to have like extensive papillary necrosis, right? Or you would have to have bilateral papillary necrosis. So really in order to have an AKI, which it is possible, I would say it needs to be bilateral and it needs to be extensive. And the likelihood of this being something that is likely going to cause an AKI, I don't want you to waste all your time thinking about it as a common cause of AKI. It's not. It can, but it's not a common cause. It would have to be super extensive because the concept here is that this tissue, this sloughed off tissue, would have to kind of get stuck here. It would have to get stuck in kind of like your ureter system. And if it gets stuck here, it causes a backup, right? So it backs the pressure up into the kidneys and impairs your filtration process. So you can see an AKI, but I'd say it's less likely. It usually needs to be bilateral renal papillary necrosis or extensive papillary necrosis. Pyelonephritis, on the other hand, this one I would say is very common. The concept here is, again, you have necrosis of this tissue. It sloughs off. When it sloughs off, it gets stuck here. And again, if it gets stuck here, what's the problem with this? Well, then again, you're going to cause a backflow. But you know what's supposed to be constantly flowing out of our genitourinary tract? Bacteria. And if bacteria is not being cleared, guess what's going to happen? The bacteria, which we'll represent here in kind of this, we'll do this pinkish color here, is going to start building up in the kidney. And if this starts building up in the kidney, it's going to cause an infection of the kidney. And that's called pyelonephritis. So with an acute kidney injury, yes, it usually needs to be bilateral or extensive necrosis to truly cause an AKI. With pyelonephritis, it can be a cause and it can also be a result of renal papillary necrosis. So that's actually really important to remember. Usually for this one, you want to watch out for fever, you want to watch out for flank pain, but I think here's the big thing. Usually when a patient has a UTI, which we haven't talked about in this system, we'll talk about an infectious disease. When you get a urinalysis with microscopy on these patients, one of the big things that helps out here is you see a couple different things. One is that you'll see that they'll have sloughed off papillary tissue. They'll have a lot of white blood cells. They'll have leukocyte esterase and nitrites, and they'll have bacteria. So when you look for a patient with pyelonephritis, look for papillary necrotic tissue. Look for increased white blood cells, right? And then usually they're in a cast formation. Another thing is look for leukocyte esterase to be positive and nitrites to be positive. And then lastly, look for the presence of bacteria to be present, right? And so these are the things that I would really want you guys to be considering in a patient who has pyelonephritis. They're gonna have pain, they're gonna have fevers, and on top of that, they're gonna have these urinary findings. With an acute kidney injury, you would more likely just see an elevation in their creatinine, all right? But it's not as common. Again, I want you to remember, less common. It just shouldn't be on the high differential of an AKI. All right, next thing, flank pain. With this necrotic tissue, again, we're kind of repeating it here, but if this tissue sloughs off and it's big enough that it obstructs the ureter system, if it obstructs the ureter system, what's going to happen? Again, we know it can cause a backflow and cause an AKI. But another thing here is it's going to cause the backflow to lead to maybe distension or kind of enlargement of the kidneys. And what's that called? Hydronephrosis. And so if a patient gets hydronephrosis, you can cause this patient to develop some flank pain. And this is because of kind of just a fluid-logged or overloaded kidney where you can't get urine to flow out because you have a sloughed off piece of dead tissue that's obstructing the ureter flow. All right? The last thing is hematuria. This is actually pretty straightforward. I wouldn't imagine it to be super complicated, but if you have this dead epithelial tissue, when you're kind of causing necrosis of the papillary tissue, remember there's small little vessels in that area. And if you rupture them, blood is going to kind of be released into the calyxes. And then they'll get dumped into the ureter system. And so it isn't very, very common in these patients, super common, that if you see sloughed epithelial tissue, guess what else you're going to see? You're going to see not just epithelial tissue there, you're going to likely see blood. And this can be macroscopic or microscopic. So hematuria is super common in combination with the papillary necrotic tissue. So when I have a patient with renal papillary necrosis, what I look for is not necessarily AKI as I would say with these. I would say look for a patient who comes in with flank pain, hematuria, potentially pyelonephritis features or features that are hard to distinguish from pyelonephritis, and then say what are their likely history. Do they have the postcards mnemonic, diabetes, NSAIDs use, etc. that we talked about? And then from there, we can do another test that we'll talk about in the diagnostic section to really help to reel us in and say, oh, this is definitely renal papillary necrosis. Without that, further going any more into this, let's now say, okay, how do we truly get a good diagnostic understanding of these tubular interstitial disorders? All right, so we've taken all of these patients and say ATN, AIN, they more likely present with an AKI. Renal papillary necrosis, more of that flank pain, the hematuria, maybe some pyelonephritis. So if I have a suspicion of any of these, I'm really going to want to have enough wide testing that I'm going to pick this up. So I'd start off with the urinalysis with microscopy. I get a phenol and I get a urine osmolality. The reason why is this is going to give me a lot of information. The urinalysis with microscopy will tell me if there's certain types of casts or slough tissue. The phenol and the urine osmolality will tell me if this is likely ATN or not. So let's say that I do this. I got white blood cell cast. Ooh, okay. Especially if it's a lot of eosinophils. That was AIN. Oh, okay, there's urine eosinophils. That's probably AIN. All right, well then, what's next? Oh, history, okay. Why am I going to get a history? Oh yeah, I'd look to see if they were having any of those darn sap medications that they were exposed to, right? So were they on diuretics of any sorts, right? But again, what was the big ones that I want you to remember? The antibiotics, the beta-lactams. Maybe rifampin is another potential one there as well. NSAIDs. And again, we talked about sulfa drugs, we talked about allopurinol, we talked about PPIs. But again, I want you to remember the PPIs, the NSAIDs, but big one is the beta-lactam antibiotics. What else was another feature in the history? Fever, rash. All right, so if I have fever, rash, eosinophilia, and then I got urine eosinophils, white cell cast, and darn sap medications, boom, I got my diagnosis. This is AIN. The next thing is if I see muddy brown cast. Oh, that was ATN. All right, cool. The phenol, the urine osmolality, though, that tells me that the tubules aren't working. So the phenol's got to be high because they're not reabsorbing it, and the urine osmolality is low because they're not reabsorbing water. All right, cool. So that's likely ATN. What do I need, though? Well, if I get the history, I got to look for ischemia, right, in scenarios of shock. So look for very poor blood pressure, so hypotension. Are they hypovolemic shock, septic shock, cardiogenic shock, or is this nephrotoxin mediated? So any kind of drugs that I talked about that are in their medical record that could be a trigger. Have they had any evidence of rhabdo? Any evidence of hemolysis? All right, cool. None. All right. Well, have they had any potential crystals? Is there any evidence of cancer that can cause tumor lysis syndrome? Oh no, is there any features that suggest like a Crab criteria, like multiple myeloma? Oh no, okay. So I got to go through those things and think about the potential history that would suggest that. But if I have the history of ischemia or I have the history of nephrotoxins, that's probably the likely trigger. And I would say with good certainty that this is probably ATN. Now, if I get this and I see sloughed off renal tissue with hematuria, then that's really making me think about a patient having more of a renal parenchymal disease in the scenario of renal papillary necrosis. But in order to truly make that diagnosis, I really want to have a patient who has something like sickle cell anemia or chronic diabetes or very chronic NSAID use, because this is a niche diagnosis. I'm looking for flank pain. I'm looking for the hematuria with, again, a non-glomerular hematuria. What does that mean again? No red blood cells, no red blood cell casts, no red blood cell casts, no dysmorphic red blood cells, no heavy proteinuria. They'll have that sloughed renal papillary tissue. If I really think that this could be, especially in sickle cell, chronic NSAID use, or diabetes, I got to get a CT urogram. And the reason why is that's going to show me that signet ring sign that usually is indicative of the necrosis here in the papilla. And that would kind of nail down my diagnosis of RPN. All right, so we've made our diagnosis of these. How do we treat each one? surprisingly, it's very straightforward. You just treat the underlying cause, right? So if the patient is if they have ATN, either way, you should avoid nephrotoxins to avoid recurrent injury, all right? So avoid that consistent injury that could worsen their ATN, worsen their AKI, and progress them to dialysis potentially. If their blood pressure's low, you got to fix it. If it's due to hypovolemia, give them fluids. If it's due to septic shock and their blood pressure's low despite fluids, then you got to give them vasopressors. Keep that blood pressure up, keep perfusing the kidney so that we don't have them have consistent damage. Because if not, their AKI can worsen, and then I got to start reaching out to my nephrology colleagues to dialyze them, especially if the patient's having refractory acidosis, refractory hyperkalemia, they're having hypervolemia that I can't diurese off, or they're having uremic complications. All right. Now, AIN, this one's actually oftentimes self-limiting. Again, you just kind of just remove the offending trigger if you can. Remove the diuretics, the antibiotics, the beta-lactams, or at least switch it if they have an infection, switch it to one that's not going to cause AIN. Try to switch it to an alternative type of antituberculosis medication. Try to avoid NSAIDs. Try to avoid the sulfa drugs if possible. Try to maybe consider an alternative drug to allopurinol. Maybe switch from a PPI to an H2RA if able. This is going to help us to reduce that recurrence of AIN. The other thing here is that with these patients, if it's in the early stages, the first 7 days of the disease, you could consider corticosteroids. But again, it's usually if the patient has severe AIN. In other words, they have a very bad AKI. That's when you would consider potentially adding on steroids. If you discontinued or switched to an alternative drug and they continue to have an AKI and it's in the first 7 days, you can give corticosteroids. It's unlikely, but a patient can progress to needing dialysis if they have the same indications that we talked about in ATN. Now, for renal papillary necrosis, this one's actually pretty straightforward. Again, we talked about that postcards mnemonic, with the big ones being sickle cell, the biggest one being the NSAID, the diabetes, and potentially obstruction. If you treat those underlying diseases, you should prevent the recurrence of renal papillary necrosis. But oftentimes, again, trying to think about those scenarios like discontinuing the medications is very important, especially if it's in this scenario. If it's sickle cell, you may have to consider giving things like hydroxyurea to reduce the incidence of these vaso-occlusive crises. If it's due to diabetes, unfortunately, there's not much that you can do except for try to improve their glycemic control, so etc. Trying to treat the underlying cause is the key. If they develop other complications related to that, such as pyelonephritis, you can give them antibiotics. If they develop an obstruction that they can't actually get through because the necrotic tissue is truly obstructing them, they may be able to go in and place a stent to allow for improvement of urine flow. All right, and that's kind of just showing us that we would take our guide wire up, try to remove that slough tissue, or at least put in a stent to improve the movement of that slough tissue and urine flow. My friends, that's tubulointerstitial diseases. I hope it made sense. I hope that you guys enjoyed it. Love you, thank you, and as always, until next time.